This week on the BackTable podcast.
I think even though for us as clinicians, and even though it doesn't really distress me very much about finding a low-grade or recurrent low-grade tumors, but I'm always reminded with my patients that it is something that is distressing for them, and just the recurrence and the anxiety around recurrence and the procedures, which even though we do them all the time, can still come with complications. And it'd be great if there were no more super recurrent low-grade tumors. So I hope that that's where we're going in the future.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Aditya Barghrodia as your host this week, and I'm very excited to introduce our guest today. We have Betsy Koehne from University of Wisconsin, and we have Amir Salmasi, one of my partners here at UC San Diego. Betsy, Amir, how are y'all doing today?
Good. Yeah, doing great. Thank you. Good to see you both.
Yeah, great. Thanks, for having us.
Well, I'm very excited about this episode. First off, to get to pick the brains of rising stars and risen stars, Betsy and Amir, really, really impactful work in bladder cancer. And sometimes I feel like low and intermediate risk bladder cancer doesn't get the attention, resources, thoughtfulness that it deserves for a variety of reasons, maybe because it's not imminently lethal. But I think it's an important disease that we manage. There's plenty of it. And maybe we'll just jump on into it. New patient comes in with the bladder mass, either on a CT scan or a cysto. How does that conversation look at that first visit?
I can start, we always, review the imaging together, and I let them know that we need to look into your bladder with a cystoscopy. And I always, recommended doing a blue light cysto, just in case that there is higher detection rate. So I explained that everything depends on what we see, pathology. If we see the mass, we talk about that. This is going to be most likely bladder cancer, but again, next step depends on the size, the pathology, is a high grade, low grade, how deep is going into the bladder. I just this is my first conversation with them, and briefly I talk to them, possible follow-ups, and I'll tell them you need to like me because you're going to be, see me a lot in the future. So we start with that, and then step by step, in the progress of the disease, we talk about next step.
Yeah, a lot of that resonates. Betsy, how about from your ends? And maybe I'll ask you to specifically comment on office cystoscopies, cytologies, adjunct tests, who, when, and how.
Yeah, that's a great question. And to be honest, I would say that I don't have a super defined pathway for whether I do an office cystoscopy before the OR. Usually if they have a pretty convincing mass on imaging, and I feel like when I meet the patient that we have a good rapport, then I'll just go to the OR with them and do the TURBT there. Sometimes I do like having the cystoscopy just because of getting the cytology, and I think it helps a little bit or sometimes a lot with counseling the patient, and can help me just know what we're getting into in the operating room. So, I think both ways of doing it. On one hand, just going to the operating room and sparing the patient the cystoscopy in the office, that's nice. And then also there can be good information gleaned from the clinic cystoscopy too. So yeah, both are good. And yeah, as Amir said, I try to indicate to the patient that we'll be seeing each other, but it's hard, when they're coming in with something and they think that they're going to get this one tumor treated, and I feel like that's the worst part of really the intermediate risk bladder cancer, is just having in the back of my head that this can be a real pain and a nuisance, as kind of the lightest way to put it.
Yeah, I think a lot of that resonates, and this might be a bit of a less common scenario, but if you referred somebody for either microscopic or gross hematuria, you take a look in their bladder in the clinic. Are there scenarios in, let's just say you see like a a very small papillary tumor, nothing kind of otherwise outstanding, no concern for carcinoma in situ, et cetera. Would you ever just do a biopsy, cauterize it, and kind of leave that as your initial diagnostic and therapeutic intervention?
For me, yes. So one of again, if Betsy said, if imaging shows like a large mass, I just, go directly to the OR. But for some microscopic hematuria or some questionable lesion in the bladder with the imaging, when I see it and it looks like a low-grade, small papillary lesion, I just do biopsy and full grade it because there's a data. And for the small masses in this size, like a papillary, looks like at 80% we can be accurate, said this is going to be low grade. And also there's another data that show that if you full grade it versus like a TURBT for this small solitary papillary lesion, they kind of like the same efficacy. So yes, I'll do it.
Yeah, I think it's definitely safe and can be nice to do that, and that you're saving OR time, which we all know is a very valuable resource. To be honest, I've done it a couple times in my clinic, but usually I don't because I'm moving on to seeing other patients, and I don't, and it's just maybe as much trouble for me at that point to just add them on to the OR for TURBT later versus having the clinic kind of get everything set up, which usually isn't set up just for a regular cystoscopy. And so that's probably the main reason why I don't do it more often, but certainly something that I think about, and I'm open to tips that other folks have about making that run smoothly in their clinic.
Well, I mean, to be honest, I think it is a relatively uncommon scenario, and not to get like super like out in the ether fringe here, but older, sicker patient, you're trying to save them a trip to the OR, small little papillary thing. I mean, for the first initial one, it seems like doing a TURBT is kind of like the textbook answer for any trainees out there, taking them to the OR, getting a good bite. But, I think in the real world, if you will, a patient that may not tolerate anesthesia so well, it may be an option. Okay, and I mean, I don't really have anything to add. Your tools in your toolkit, you have imaging, so that kind of checks the box on your CT scan and office cystoscopy, and there are pros and cons. Many times if it shows like a tumor near the UO, I like to look just so I can kind of prep them for they may get a stent or, something along those lines of cytology. I think just to, again, start that conversation of, what are we kind of looking like here? All right, so let's just say that your sense is this is not some super aggressive, high-grade tumor where there's going to be a lot involved. Next trip is to the OR. Amir, it sounds like if it's available, your preference is to do this with some type of augmented cystoscopy, blue light, et cetera. Is that about right?
Yeah, I like to we use a lot, blue light. The other one is a good too. So it's not going to helpful that much about finding the papillary lesion. Is mostly to finding the CIS lesion. And I think, this technology, when we have as an easy access, I think increases our detection and sometimes change the patient's management. But again, if it's like only one solitary lesion, and there's nothing there, and the first time, you don't have that high suspicion, he's not a smoker, there's no gross hematuria, you can, there's no strong evidence that, blue light is going to help. But overall, my preference is that using some, adjunct, imaging-based evaluation. Yeah.
Betsy, anything on top of that?
I don't often use blue light for the first TURBT. When someone first comes to see me and it's a new bladder tumor, new diagnosis, and some of that is also just various hospitals. The equipment for blue light can be older, and imaging is, even though it's enhanced imaging, is actually maybe not as good. I do like it for intermediate risk, or these people who have these recurrent tiny little papillary tumors, even though the blue light data doesn't really show that it helps a little bit with detection and probably doesn't maybe overall change outcomes, but it's nice. I feel like it really helps highlight those little tiny tumors that are around the bladder, and makes me feel good that when I am going in to take these out, that probably got all of them. And that's something that I will give John Gore at University of Washington a shout out for, because he really pointed out that use to me. And anecdotally, I feel like that's a good tool for a good use for blue light in this type of patient.
Yeah. I mean, I'll generally try to employ it if it's available. And sometimes I'm surprised, even for a relatively low-grade papillary appearing tumor without any associated carcinoma in situ, that there's almost this like carpeting of like pre-invasive, pre-cancerous lesions. These are sometimes ones that I'll biopsy in the clinic, and it says incipient papillary formation, suggestive of like a super early tumor. And who knows? I mean, a 3-month recurrence, that's not a new tumor. That's a tumor that wasn't eradicated the last go around. And then I think what you're kind of mentioning, Betsy, sometimes it's amazing. You'll do blue light and there's literally like, you can almost see like 4 cells of like a super duper early papillary something or other. And there's like, it's like a starry sky of them. And on the one hand, they're going to come back, but at least you feel like you cleaned them out reasonably well. Okay, so I'm a resident, maybe a junior resident. They got assigned to cover your TURBTs for the day. Let's walk through the Betsy and Amir kind of, here's what you got to do at the TURBT to really max benefit this patient.
Yeah, and so it's always good to remind the residents to start with a bimanual exam, even though for these little low-grade tumors, you're probably not going to, we don't really expect to feel extravesical extension, but it's good to have them get in the habit of that. And then depends a little bit on the size of the tumor. And for smaller tumors, I like to just cold cup resect them. And if I can have the equipment to use the continuous flow with the cold cup biopsy forceps, that's pretty nice, so that you can keep seeing while you're just plucking out the tumor. And then if it's a little bit larger, then I'll use the loop and for a bipolar resection. And then usually for this situation, I would leave chemo in the bladder for an hour at the end.
Yeah, similar.
I'm going to dig in a little bit on this situation, because I do feel like this is a source of some consternation for the trainees and in the community as well. Amir, let's hear from your end also.
Kind of, similar, but if it's something like a larger, I use like a bipolar and loop. And I always talk about the residents, if it's like on the lateral large tumor, and I ask the kid to paralyze the patient. I tell the resident to try to cut in the lower volume. Also, just not like a continuous cutting, just kind of have to stop, and make sure that there's no obturator reflex. And always also say, hook it behind the tumor, always see where's the UO, where's the wall of the bladder, and just bring it to yourself. Sometimes I feel like a resident's like heat up the loop first and then start, cutting, and then from, it just goes so deep and make a hole. Say, no, hook it first, then heat it up, always know where's the wall. And as soon as I cut the tumor first and I go deeper bites, and I send a separate biopsy, deeper. And always we have a documentation. We always, ask the resident to document. He was visually muscle, specimen. Are we visually did a complete resection? He was concerned about CIS. We was a perforation, and all of them, we just documented in our uplift.
Yeah, perfect. Yeah, just getting those. I mean, Chris Anderson did some really nice work on those kind of critical elements of an op report, and I love talking about TURBTs because I also think they're underrated, and did what I thought was a really fun episode one time with Sam Chang. So if you're interested in TURBT, just to make sure we don't get too far again off kilter, that's a good one. Okay, so Betsy, this is, I think, post-operative installation. That's always one where, I don't want to say that I'm like leading the residents, and some of it's like read my mind, but it's such an important thing, right? It's one of the few things, like if you think of something at the point of care, it gets done. If you don't think about it, that's a missed opportunity. So who are we using a post-operative installation of gemcitabine? I think these days is probably the kind of preferred option over mitomycin. Who's that going to be in your hands?
A little bit going back to our earlier conversation, if they had a cystoscopy in clinic, or maybe by myself or one of my partners in this, cytology was negative, and then we're expecting it's probably, and just based on the visual inspection, it's probably going to be a low-grade tumor. Usually for all tumors that I think are low-grade, I just do the intravesical chemotherapy. I think there's some evidence that in people who have recurrent tumors, multifocal low-grade tumors, the 1 hour adjuvant intravesical chemotherapy probably isn't going to change outcomes. And those people really just need a full adjuvant course after the procedure. But I usually just do it at that time to kind of keep things more consistent from case to case.
Absolutely, I agree with you. I think the data shows that if for effective for a small solitary tumors, but again, if I feel like anyone is a low grade tumor, I give it like a gemcitabine after the surgery, and also we have to make sure that there's no perforation.
Yeah, I mean, I agree. And I remember when I was a trainee, like I feel like Yair Lotan set me up for this and just kind of walked me down, and it was effectively beaten to my head that's really the solitary tumors less than 3 centimeters that are really going to benefit. But like you guys are saying, older, sicker patients, recurrent, low grade, you haven't perfed them, you kind of know their natural history, that the downside is somewhat limited. And if you can save them a trip to the OR. One question that kind of came up, fulgurating, so, multifocal, papillary, low-grade appearing tumors. Any strong opinions on resecting versus cauterizing those?
For me, if patient has we've seen a multifocal, small, papillary lesion, tiny everywhere, I think I usually, biopsy 1 or 2 that I have a tissue, for a pathology, but then I just full grade the rest of it. So I don't think that there's any, because they're so superficial, you feel comfortable, that I'll full grade the rest of them. I don't resect all the small, papillary lesions.
Yeah, I agree with Amir.
Yeah, a couple good ones. You're feeling like you've got a good sampling. You haven't cauterized it. The kingdom come to the pathologist can make some sense of it, and that's that. All right, very good. So we get them out, and they're coming back into their clinic, and maybe this is a good time just to kind of make sure we're all on the same wavelength here. Low and intermediate risk bladder cancer. That's the title and the topic of today's conversation. You're looking at that pathology report. We're about to sit down with the patient. You're just kind of checking out things one more time before you go in. What are the kind of critical bits here on the pathology report to review? And
yeah, so a low grade, low risk bladder cancer, a low risk non-muscle invasive bladder cancer will be a low grade TA tumor, so a low grade non-invasive tumor less than 3 centimeters, and then essentially any low grade that is larger than that or multifocal will be intermediate risk, and then small high-grade tumors will also be intermediate risk.
All right, that's our AUA.
By myself, I don't put anyone as a high-grade cancer, regardless of size. I'll like to be put in the high-risk group. So there's a data from the European guidelines. They put in a high-risk group. And also there's a study came from a Kamat team that, showed that the high-grade TA behaves like a high risk. It's not like it behaves intermediate risk cancer. So I personally agree with that classification that I put even like a small high-grade tumor in the intermediate risk group.
Yeah, no, I agree. I've seen that evidence that even small high-grade tumors are high risk. And so, yeah, typically we'll watch those extra closely or maybe just follow the high risk category depending on the patient. Every once in a while, I feel like recently I've had a handful of patients who have maybe like focal high grade histology amongst a background of low grade. Have you seen that recently? And
again, I feel like I think the field is going towards this way too. I think the intermediate, we agree about who's a low risk, and we agree who's a high risk. And I think the intermediate risk groups is very heterogeneous, and not all of them, based on the criteria we have, behave the same. And this is coming to the new concept of the IBC group. They are putting the intermediate group risk in the low risk group, intermediate and high risk. So based on how many of the other risk factor they have, for example, size, like a multifocal disease, like a early recurrence, or receive the treatment before. Based on all of this, they put the patients again in another category, low intermediate risk. And I think that is like a more, I know, is like the approach we should in the future. We take that approach because it's very heterogeneous group. We're putting them, as you said, some of them going to behave nothing and some of them is going to go towards a high risk group.
Yeah. And I mean, that's where it always lands, right? I mean, and well, even the low risk, like 2 papillary 1 centimeter tumors, I'm not too excited or concerned about that, but that's technically intermediate risk. A 2.7 centimeter TA high grade, that's got my attention. And, the Europeans, they have 4 categories. As obviously, you guys are well aware, where there's a very high risk, the high risk, intermediate, and the low. And I think that very high risk is probably worthy of a separate conversation. All right, path report. So, I mean, I almost feel like the low grade and the high grade, focus of high grade and background of low grade kind of drives me crazy. I'll just throw it out there. I kind of more lump that into low grade and feel like that's our pathologist doing what they should do. Just, it's not always black and white, and they're probably hedging a little bit on giving us this isn't totally innocuous. But if it's low grade muscle in the specimen, despite the fact that you saw it and visualized, if they don't call it, I wouldn't go back for a TUR. If it's a TA high grade, solitary, kind of what we're talking about, intermediate risk, I wouldn't reflexively do that, but I might consider it. But yeah, maybe just muscle in the specimen, is that a big deal to you all? And perhaps, since you both are at academic centers, how does this change if you did the initial diagnostic TURBT versus something that's referred in to you?
Yeah, as you said, I don't typically worry that much if there was not muscle in the specimen. If I did the TURBT and feel good about a visually complete resection and we saw muscle and it's a low grade tumor, and depends on the patient too and about the risks of going back to the OR for them in a relatively short interval for a restaging TURBT. But typically I wouldn't do that. High grade TA, I would say if I did the TURBT and felt good about it, I probably would not. I usually don't do that anymore. But if it was someone that was referred to me and the patient had high grade TA, no muscle in the specimen, I'd definitely take them back to the OR for a restaging.
Yeah, I agree. I do the same thing. If anyone, comes from outside, at least I do the cysto in office. And but there's no muscle, is a high grade or invasive, I always re-TUR by myself to make sure they have a muscle. If I do by myself, and I'm very, sometimes, we really know that you went so deep, despite the fact that you see the fact, but the pathology report comes back and no muscle in the specimen. I don't repeat that. But sometimes, I worry about that and just there's no muscle in the specimen. Even I do it by myself, I'll bring it back again for re-TUR. So I think, when you're dealing with a high-grade cancer, it's a serious disease, and I'm not worried about to bring the patient back one more time just to another surgery for better staging.
Okay, so yeah, right. It's all kind of case by case, and not everything kind of bends in. You're looking at comorbidities. I think office cysto is a nice kind of intermediate option for people that are coming in. Do you know the person referring them? And it kind of goes on and on. All right, so let's start out with low-grade tumors. Cover the gamut of multifocal, unifocal, small, large. You're taking it all in. Let's just say it's all going to be low grade. How does this conversation look like with your patient? First time, they're coming back from their TURBT, they're doing great, they're no blood, urinating fine, and you're reviewing the pathology. But actually, let me back up. Do you release the pathology on my chart or EHR du jour, or do you wait till you have the conversation? What does that actually look like?
I prefer they hear from me because they're going to create some anxiety. And so, but some, and we usually have the post-op in 2 weeks to come and talk to me. Sometimes they call in advance and they want to know, but I prefer that to discuss by myself because I feel like some cancers may be straightforward. For bladder cancer is a little bit more challenging and a personalized option. So I prefer to discuss by myself.
I suspect most of us use Epic, but the different Epic iterations that I've used recently will automatically release it, and then or some of them will automatically release it, and then some won't. And so perhaps even if I don't release it, patients will be able to see it anyway. I try to, if I remember, but I try to warn the patient that they will probably be able to see their pathology report And then usually we'll make a telephone visit or in-person visit to review the pathology. And then if I see it ahead of time, usually I do see it ahead of time, but I'll try to maybe send them just a little blurb with the My Chart message and then say that we'll discuss it further at our follow-up. And so no matter what we're going to talk about, it's just more of a kind of clinic management about the timing. And
yeah, I mean, we're always, I think, a little bit reluctant to prognosticate or reassure patients until we have that pathology. But I think it kind of starts out like from the first time, right? If it's an office cysto and it's something small, like our job is to talk this person off the ledge who's probably freaking out because they have a diagnosis of cancer and they have no idea that this is a low risk, low grade bladder cancer that's never going to pose any threat to their life. At the TURBT, iterating that again to the family that, hey, you're going to be okay. This is something we just have to manage. Like you guys said, we're going to be friends for a long time. And then, at that first meeting, like when I walk in, it's almost very similar to low and intermediate risk prostate cancer. When I walk in, the first thing I say, if it's low grade, is you're going to be okay. You're not going to die. This isn't pancreatic cancer. This isn't lung cancer. This is low grade, low stage bladder cancer. It's more of an inconvenience than anything that poses a threat to your life. Sound about right?
yes.
Okay. So, all right, they're there, they're doing okay. And let's just say it's a 2-3 centimeter unifocal or multifocal low grade. And maybe we can take both of those. Maybe, Betsy, you want to give a unifocal low grade, and Amir, we can have you give a multifocal low grade. What is your spiel, Betsy, so to speak?
Yeah, so I would also start with reassuring the patient that it's not a lethal cancer and that really the chance that this is going to progress to something more aggressive is really, really low. However, the chance that it recurs is quite high, and I usually give a ballpark of 50% for their first tumor. And so then I say that and if it was a solitary low grade tumor, and they had the intravesical chemo at the time of the TURBT, then usually I wouldn't do any adjuvant intravesical chemo after that for a real low risk non-muscle invasive tumor. And I would do a surveillance cystoscopy in clinic in a few months.
That sounds perfect. I mean, I think if they're smoking, it's a good time to just remind them that the likelihood of these coming back is lower if they quit. Sometimes that is what they need. And totally. And I kind of prep them that if it comes back, we're not going to freak out. And our clinic is pretty agile at getting a biopsy fulguration going like pronto. And I'll always have the next cysto kind of set up for a possible biopsy fulguration in the clinic. But yeah, that sounds right. Do you using any prognostication tools? Are you busting out any calculators or just giving it the more clinical gestalt low risk?
Yeah, there are like the IBCG, the International Bladder Cancer Group. They have some the risk tables that can be converted into risk of recurrence and progression. And I don't usually use those for the first solitary low grade tumor. And truthfully, I don't use it that often after we're already doing repeat TURBTs. I feel like we're more focusing on what else can we try to prevent this from coming back. But I think that from an educational perspective, those are good to have when working with residents in clinic, for example, to help conceptualize the natural history of this disease.
Yeah, I agree
Totally.
with you. And again, that's like the low risk group that I'll tell them that it's going to come back, but most likely it's not going to progress. It's not going to something that's going to kill you. And again, that's going to be a personalized approach. I don't put anyone on just give one episode of the one small tumor, low grade. I usually don't cysto them in 3 months. I do at least like a 6 months cysto unless they develop some symptoms, gross hematuria. And even they're old, I try to, increase that interval because there's a good data about the active surveillance on the, low risk small tumors. If someone is old, I can, and frail, I'll tell them, we can just for a year and a half. Again, it's personalized, but overall, as my standard is guidelines, I offer them 6 months cystoscopy and reevaluate. And if they have another recurrence, they change the class to the intermediate risk. Then we discuss about the adjuvant treatments into the bladder, for 1 year. But if someone comes with a DTS question from the beginning, I put in the intermediate risk group that have a multifocal disease or like a low risk, a low grade, but there's a large tumor. So that's different story. So then I like, if you want to be a little bit aggressive or more conservative approach, need to be on the treatment, like intravesical chemo, induction, 6 weeks, followed with the monthly maintenance up to 1 year. But if you want to wait to see another, in 3 months, another episodes of recurrence, then you're going to go that path. I'm going to say there's no data compare these two. I'll offer both of them. And of course, there's a bunch of trials. I think at one point we can discuss them.
Okay, so for the solitaries, yeah, I mean, all my counseling is very similar, that we have two goals here: to keep these from coming back after recurrence and from progressing into more dangerous things. And like you all said, and I think prepping them so that if and when they have a recurrence, they're not like, oh my gosh, this is like the beginning of the end. I tend to be more on the 3-month cysto for the solitaries, because if they have a recurrence, most of the time you can just manage it in the clinic and save them in OR if it's a little bit bigger than you are, I think, committed to the OR. And then, well, Betsy, in terms of the multifocal low grade or larger low grade that puts you in intermediate risk category, any additions on top of what Amir said?
No, I would just echo what Amir said. And for that situation, I would discuss with the patient pros and cons of doing an induction intravesical chemo course with typically gemcitabine. I don't normally push the patient if it's their first resection and they had multifocal low grade TA. I usually just see how they feel, and if they want to be more active, and then we can do that. Or if they want to just see how it goes, then I feel like that's fine too for that situation, since there is such a relatively low risk of progression that we always have that tool in our pocket.
Yeah, I mean, I generally will give them all options, but kind of at the end of the day, if you were my dad or my brother or whoever, would probably just monitor it and look in 3 months. If they ask, what would you do, doc? And maybe it's the TA, the low grade, small focus of high grade. T1 low grade, that always is a bit of a weird entity. First off, a little bit challenging to believe, just given the incidents. Anything of T1 low grade, what do you guys think about that?
Yeah, no, I agree. That's not a typical diagnosis. And I would, especially if it was from a community pathologist, I would definitely have that re-reviewed by a GU pathologist at my academic institution. And then if it was at my own academic institution, I'd probably, just out of curiosity, reach out to the pathologist, because it is something that some people don't believe in.
Yeah, I don't believe in it too. But again, I don't know how we stage it or which category I put it. I don't think that low-grade cancer can, invade to lamina propria. But if it's true, or so which category it is. So I don't know. That's like a challenge. So
no, I agree. Those are not super straightforward. Okay, so I guess for the sake of completeness, small TA, high grade, what does that conversation look like? Unifocal, which would technically be intermediate risk per AUA guidelines.
For me, I highly recommend, to patient receives the adjuvant treatment. And so maybe not for 3 years, as a swab trial, maybe at least 1 year. And then highly recommended to elect, from the gemdosi versus BCG. Again, we have a trial, and you're our local PI, the British trial, push for it. And I highly recommend it for even there's a small high-grade papillary to consider the adjuvant treatment.
I would also use intravesical adjuvant treatment for that situation. And I think also would depend on whether we were in a more acute BCG shortage kind of time, or whether there was BCG, about whether I would go with chemotherapy or BCG in that situation. And then also the patient's tolerance with gemdosi of having multiple installations and just spending longer in clinic. That's also something that I bring up with them when considering that.
Is it fair to infer that if BCG were abundantly available, BCG would be the preferred intravesical option for a TA high-grade tumor? I mean, it would for me. Or the trial would be the preferred option, preferred. And I mean, in the guidelines, it says intravesical immunotherapy or intravesical chemotherapy. If you're using chemotherapy, is this single agent gemcitabine? Is it gemdosi? Is it something else?
For me, it's the gemdosi. I don't believe in the single agent chemo as adjuvant treatment, and only single agent is just for the perioperative time. But for induction and maintenance, I highly also recommend the maintenance. I'll give a combination of the gemdosi.
Yeah, I would also try to use at least combination gemdosi if we're doing chemotherapy for a high-grade tumor. And so I agree with Amir.
And maybe taking a step back, if it was a multifocal low grade or a larger low grade that puts you in intermediate risk, is that intravesical chemotherapy single agent or is it combination?
I would typically start with single agent if they wanted to do intravesical chemo, and you can always go up from there. But I think that's in the space where you're not usually going to lose any ground in terms of progression risk. So I think it's reasonable to start with less.
But you mean a single agent as a preoperative, treatment, or just like you as an induction?
No, like weekly gemcitabine, if like a multifocal low grade. So Betsy, I would agree with you. If they had like multifocal low grade and they wanted to be aggressive and proactive, I would say, okay, we can do 6 weeks of induction gemcitabine and then monthly gemcitabine. And even that can be a bit of a debate depending on how everything kind of went with the first go around for a low grade. Okay, so if they progress, maybe we won't focus so much on that because I think that can go into progress to higher grade tumors. That leads us into the whole conversation of BCG refractory disease. But how about, all right, 3 months cysto and they didn't receive anything and now they've got multifocal low grade tumors. And perhaps just for the sake of time, we completely resect those, whether that's a biopsy resection in the clinic or a trip to the OR. Now what? Now they're squarely in intermediate risk, however they sort it out, right? Betsy, maybe we start off with you.
Yep. And so if they hadn't had intravesical gemcitabine yet, I would just start with that. I rarely use mitomycin C. I think I just grew up in the urology world where people were scarred by that. So I don't usually use it, although I have more recently seen people using it and saying that it's going okay. And then otherwise after that would see if we had a clinical trial open for another agent. But typically I would just start with intravesical monotherapy gemcitabine if they hadn't had that yet.
Yeah, I think that for a patient with the intermediate risk now, we have more options. We can personalize the treatment, and especially, for example, some are older, you don't need to bring to the operating room as on the trial. The chemoablation options, patient received the surgery, TURBT, we can discuss the adjuvant options. So adjuvant options can be, again, as like Betsy mentioned, be an intravesical treatment, most likely intravesical chemo, or you can discuss like a clinical trials as an adjuvant setting. If patient has a mutation, FGFR mutation, we can put the Moonrise, the TAR-210 that releases the erdafitinib, and or if you want to discuss the chemoablation that without resection, then you can talk about the UGN-102 that puts the gel with the mitomycin in the bladder. I think the fields are going like a more and more discussion and conversation and treatment upfront in the intermediate risk bladder cancer is like a kind of be tailored towards like a patient. If you look at this old lady, we don't want to bring it to the operating room on a frequent basis. Maybe we go to the chemoablation, or someone with a multiple medical problem. There is a person that wants to receive a more treatment after that. We can always talk about the new trial and Moonrise or intravesical gemdosi. Yes.
Yeah. Okay. So maybe I think it is an exciting time where we're getting more options, and perhaps thinking about this, let's just say that we're at a community practice without extensive access to trials, or we're out in a not urban environment. The tools in our toolkit are mono agent chemotherapy, doublet chemotherapy, gemcitabine, docetaxel, and BCG. Are those kind of what you're thinking about as the current standards for somebody? Betsy, you'd mentioned that you started out with single agent chemo. If that doesn't work, what's your next kind of option for the patient?
Yeah, yep. If monotherapy gemcitabine doesn't work and I have access to BCG, I would try BCG next. I don't know if the evidence can help us decide between doing BCG or a gemdosi next. I suspect either, or I feel that either would be fine after monotherapy.
Amir, what do you think?
Yeah, for me, if it's a little bit like a higher risk, like a multifocal, the larger tumor size, I'll go mostly toward like a combination than monotherapy. But if it's just like a small papillary lesion, just like recurrent, I start with the, monotherapy, and then if no treatment, either way, I don't think there's any strong, opinion between the BCG or gemdosi.
Yeah, I agree. And, there's no nevers or always. For some reason, I just hate using BCG for low-grade disease. It just seems like it's like bringing a gun to a knife fight. It's based on nothing other than feels odd, and, God forbid they got sepsis or something. And on the other hand, gemdosi, it's like, well, half of that combination didn't work the first time, so I'm not like beyond thrilled to use it. But I guess if I have to land somewhere, I'll typically honestly go gemdosi. If that doesn't work, then and again, assume we haven't had the trials discussion yet, then go to BCG. And we are affected by the BCG shortages, and so that's not the main driver here. But and I also just make sure that somewhere along that rhythm, I get repeat upper tract imaging to make sure that I don't have some tumor up top that's seeding the bladder. Does this all sound reasonable? Anything you'd add on top of that?
Yeah, for me, it's like reasonable.
Yeah, no, I agree. And I think the clinic setting really affects whether it's easier to do gemdosi or BCG next. And at the VA where I'm at now, we don't have docetaxel set up yet, so it would be easier to just do BCG in that situation. But in a few months, we'll have gemdosi set up. So then.
But again, I feel like, especially if you're talking to the community doctors, urologists, I think the most important is like a risk stratification. And as you said, the BCG is not going to work for the people with the low risk bladder cancer. We should, stop, overutilization of the BCG for a low risk. And I think that's like the first step, like appropriate risk stratification. And based on that, then guidelines comes into play that BCG is not the treatment of choice for every bladder cancer.
Okay. Well, let's talk a little bit about the trials. So you mentioned targeted therapies, FGFR3 inhibitors. You mentioned chemoablation, and maybe we could at least spend a moment about that. Any familiarity with UGN 102? Does either of you all want to give us a little quick walk through what that is, how it's instilled?
I can talk about the UGN. So that use like the delivery system is like a thermogel, we call RT gel. So this gel, when it's in the cold temperature, is a liquid. But it goes to body temperature, it just forms a gel. And it stays longer time. And then instead of it just drain right away, it takes about 6 or 8 hours, the body get rid of this gel. And when we put the mitomycin in this gel, we administer it through the catheter into the bladder. It stays longer time, and over the 6-8 hours, patient urinates and eliminates the drugs. So the concept comes towards like a chemoablation. So I said if the people has like a small multifocal or intermediate risk bladder cancer, are we worth it? We give this treatment, or we should go and surgically remove it. So there was a true trial. They used like a phase 3 trial. One of them was an Atlas trial that was a randomized trial that compared to people receive a UGN 1 or 2, and if they had a recurrence, they go to the TUR transurethral resection. So it was like one arm was like a UGN plus minus TUR, and the control arm was just a TUR with no adjuvant treatment. So at 3 months, complete response rate in these two groups was similar, but the long term, in 15 months, the people that receive a UGN upfront had like a 72% response rate versus a 50% of the people with the TURBT. So there was some problem with this trial because they stopped it early, the sponsor, because they want to try to take a different agent, but it's not powered based on this patient that they recruited, but overall showed that like a signal towards like a better outcome of the people receive this UGN upfront, then they go TUR. And the other thing was like the people with the TURBT arm did not receive any adjuvant treatment. So they did another trial. They got to envision was like a phase 3, but single arm, that only people just receive the UGN 102, and in 3 months, if they have a complete response, they follow. And anytime they have a recurrence, start of a care, TURBT, adjuvant treatment. And based on that, also they showed that very high complete response rate in 3 months after the UGN 102. So I think that it's going to be approved early in 2025 for intermediate risk bladder cancer, for the people with the intermediate risk bladder cancer that has like a multifocal small, and then we think that maybe we don't want to bring it to the, for some reason, to the operating room, or we discuss the patient, or patient prefers that. So that is like one of these trials is like use the UGN 102.
Thanks, Amir. Yeah, I think it's exciting, and it's really nice that there are companies paying attention to this relatively niche disease state. And Betsy, maybe I could just ask you to give us a little flavor for some of the trials that have you excited about, next options for our patients.
And so Amir mentioned earlier the erdafitinib pretzel, the TAR-210, and which he also mentioned earlier. But so about 60 to 80% of low-grade non-muscle-invasive bladder tumors will have an FGFR 2 or 3 alteration, which is we think is an oncogenic driver. And so those are susceptible to erdafitinib. And they initially looked at this in the THOR-2 study. There was an exploratory cohort in which patients had an oral dose of erdafitinib, and that was a trial in which they left a marker tumor. So they did a TURBT, but left one of like 5 to 10 millimeter tumor, and then looked at follow-up, and they had pretty good rates of response, but there was toxicity as it was a systemic treatment. And so now they've been doing the TAR-210 with the pretzel. And so far, I think at ESMO in 2023, they had just had results from about 15 patients, but they had 87% with a complete response. It was a very early response rate, but I think that mechanistically it's exciting from just the way that it's a great example of us learning more about the biology of the disease and applying a more kind of targeted treatment. And hopefully this would be something that a very different mechanism, and maybe something will be a different, give us more lasting results. And then I think I heard CG0700, which I can't remember the pronunciation for, but I think that maybe SUO is doing the multi-site trial for that in intermediate risk coming up.
The other one is just adstiladrin. So adstiladrin also has in adjuvant setting for an intermediate risk bladder cancer. The patient has an intermediate risk. They receive a quarterly of adstiladrin that it is a adenovirus that induces interferon, one of the elements of the immune response in the bladder. They had a good results in the BCG unresponsive. Now they're bringing to the earlier stage and the intermediate risk. That one also patients there's a randomized trial, and if people on the control arm develop recurrence to crossover, they can receive the adstiladrin. So it's another interesting trial, exciting trial.
Yeah, I mean it kind of makes sense, right? It's like you start out with the BCG unresponsive, and then it's BCG naive for high risk, and now it's more like intermediate risk. And I mean, it's a crazy thought. It's exciting that you have these tools in your toolkit for people with maybe non-life-threatening but recurrent and highly inconvenient bladder cancer. It's also like a trip that they could be receiving medications that are like literally like gazillions of dollars. Yeah, and I guess as things mature and perhaps get out of their period of being proprietary, et cetera, it's really cool to see these things and meet patients where they're at. So, and I guess it's worth asking. I'm curious, have you guys ever done a cystectomy for recurrent low-grade bladder cancer?
No, never.
Yeah, I mean, it's like, you don't want to do that like at all cost. And, That also, I said BCG for low grade seems wrong, and a cystectomy for low grade seems awful. But I don't discount how psychologically and physically challenging. I mean, sometimes people get a TURBT and they're off for like a month, and it's like a whole thing. So it's nice to see these options. Here it is. We've been an hour talking about low risk and intermediate risk bladder cancer, and want to be respectful of your all's time. Perhaps as we wrap up, any kind of parting thoughts for the listenership?
Well, I would just echo what you're saying is that I think even though for us as clinicians, and even though it doesn't really distress me very much about finding a low grade or recurrent low grade tumors, but I'm always reminded with my patients that it is something that is distressing for them, and just the recurrence and the anxiety around recurrence and the procedures, which even though we do them all the time, can still come with complications. And it'd be great if there were no more super recurrent low-grade tumors. So I hope that that's where we're going in the future.
Yeah, I agree. I think that despite that most of this group of people, they're not going to progress, they're not going to die from the bladder cancer, but the cost of the treatment and doing the cystoscopies and all the surgery, tremendous on the patient, for years and years and years. I think we need to find a way to kind of the intensified treatment for the lower risk people in this group. So, and again, it comes to the active surveillance for lower risk group, or some trials that we just do it and or biomarkers that prevents doing multiple cystoscopies. There's lots of, stuff, I think what we need to do for these two category. And despite that, they're not going to die from this cancer, but still it's going to have a large impact on their quality of life and then cost of our health system.
I couldn't agree more. And one thing that just occurred to me in my last parting thought is I always tell patients and give them a BCAN brochure. It's a wonderful resource. I think it's a real top-notch educational and hope-inspiring community. Our local BCAN chapter, shout out to them, is beyond amazing. So providing that resource is a no-brainer. All right, Betsy, Amir, it was a true pleasure having you all. Thanks for your insight on managing this, and look forward to catching up at this UO. Thank you.
Thank you.
Great. Thank you. Thanks for having us.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.